I'm just going to be presenting on some preliminary work that we've been doing on the Afla cohort study. The title when we submitted the abstract was Factors Associated with Serum Aflatoxin Levels in Pregnant Women. And I think it's more like, what did we test as factors that might be associated? So I just want to give you a disclaimer that this is work in progress, but it's such interesting results that we really think we really bring it to you for us to really think about what's going on when it comes to aflatoxin contamination in Banke. This is a huge effort that's being undertaken in Banke, Nepal. It's about 1,670 women, as Joanna pointed out, which means that we have a massive amount of collaboration and a big team down in Banke. And special thanks to CHD and to Patton Academy of Sciences, Helen Keller, our partners at Purdue and University of Georgia, who are making it possible for us to implement such a large study. We are supported by the USAID Bureau of Food Security as well as USAID Nepal. And we've got a huge team at Tufts, as well as in Banke, we have the Tufts and HKI team, a total of 50 enumerators and field guides and assistants. So it's a big operation. But of course, the most important thing is we've got 1,676 moms. Turns out we have 6 more than what we were supposed to enroll. And they're newborns, and some of them are already born, and some of them are yet to be born. So it's a lot of what we are doing is only possible because these individuals are allowing us to come into their houses and allowing us to ask them really, really intense and long sessions of questions. So a little bit of the introduction. Joanna's mentioned a little bit about what are aflatoxins, and there's linkages with linear growth. Obviously, we know that linear growth issues begin often at the fetal stages. So really, there is some literature that's pointing out to the fact that aflatoxin exposure in utero and early life could be associated with linear growth. The evidence that exists, is, as Joanna has said, is primarily in Africa, and a lot of it has been done around, which is cross-sectional work, but there is some longitudinal data that's emerging. What we don't find is large-scale studies that are sort of powered enough to see the relationships of aflatoxin exposure to household factors, individual factors. And so that's really what Afla cohort is going to be all about. We do know, and Keith West presented in the 2014 symposium a fantastic paper which had looked at aflatoxin exposure in the first and third trimester, and then what happened to infants at 2 years of age in Bangladesh, and there was some data from Nepal as well. So we do know that that link does exist. So what we want to do is to take that further and understand how it affects birth outcomes, for instance, low birth weight, which is extremely prevalent in South Asia, and then subsequently linear growth. So this is just to show you a little bit of what the Innovation Lab has been doing in Africa, and this has very much relevance to our Afla cohort study. This is data that is coming out of one of our PhD students, Barnabas Natamba from Uganda, and these are HIV positive and negative women. So what you have in the red bars are women who are HIV positive with high and low levels of aflatoxin, and in the green bars you have HIV negative women who are either low or high aflatoxin level. We find that the HIV positive women with high aflatoxin level had infants at 12 months of age who had significantly lower Z-scores than women who were HIV negative and low aflatoxin level. There is work that is showing that inflammation and infection does have some sort of synergism when it comes to aflatoxin. What was interesting is that we do see, even in the HIV negative women, while it's not statistically significant in this group, there is a lower Z-score, height for AIDS Z-score compared to the ones which are HIV negative and low aflatoxin. This is obviously Groupman, and Keith West is one of the authors on this. I was just talking about that. What you're looking here is data from Bangladesh on 63 women, and they had data from the first trimester and the third trimester. These are serum samples that were analyzed for aflatoxin, and they had cord blood. So what it's telling you is essentially women in their first and third trimester had aflatoxin levels that were similar. There was no difference, and it appeared in the cord blood. So that's telling you that there is potential to transfer and metabolize aflatoxin. And at 2 years of age, these infants still had aflatoxin. Obviously, there is introduction of aflatoxin through complementary foods and lots of different elements that are probably going on between the first trimester to the 2 years of life. So that's really what we are interested in understanding in the Afla cohort study. So what are the objectives of this particular presentation? When we had, in March, when we submitted the abstract, we had about 800 samples, and we thought it would be very interesting to look at, do we actually see any aflatoxin exposure in the subsample of women that we have been recruiting? And what's the extent of the exposure? What's the percentage of detection? Because that's really the basis of, if there is no aflatoxin exposure, then the question is moot. And then can we identify factors that are associated with those aflatoxin levels in pregnant women? So I'm just going to go into the short sort of description of Aflacohort study and move on to the results. So Aflacohort is a rolling cohort study. We just closed enrollment a couple of weeks ago, and it's being conducted in 17 VDCs in Banke, Nepal. We have about 6 to 7 visits planned at around 3-month intervals, and the recruitment starts in pregnancy. And we have follow-ups at birth, 3, 6, 9, and 12 months of age. We collect a venous sample from the mother in the pregnancy time point, and then from the infant at 3, 6, and 12 months. And as I mentioned, we had, at the time that we were submitting these abstracts, we had about 800 samples that were already at the University of Georgia for analysis. So we decided to look at serum aflatoxin B1 lysine adduct, that's how it's analyzed, in picograms per milligram albumin using an HPLC method. That is a standard method that's used. So just to give you an idea of the kind of descriptives we've been running, we're looking obviously at the serum aflatoxin levels themselves, but looking at other factors around the mother, whether it's individual or household level factors ranging from her health and nutritional status to her food frequency pattern. We used a 7-day food frequency questionnaire. We looked at antenatal care usage, food security, wealth, age, the trimester that the mother was in, as well as the production and purchase of different food items. And we looked at mean standard deviations, medians, and interquartile ranges. So we had to work on log transformations and for the serum aflatoxin data, and we did bivariate correlations and analysis using different methods to understand bivariate correlations. So let me tell you what's the first thing that we find. First of all, the detection rate is, we have about 95% of the samples that were analyzed, of the 810, had detectable aflatoxin level. And a detectable aflatoxin level is greater than 0.4 picograms per milligram of albumin. And so it's only about 5% of the women in our subsample have no aflatoxin, or undetectable. It's less than a certain amount. What's the next thing? So how does this distribution look? And this is where things get very interesting. And this is not unusual at all for aflatoxin. We've seen it in other studies that we've done. What you see is a very skewed distribution where you have a lot of people who are at a very low level, but then you have a massive tail, almost up to 100 and more. We have a few points here, which you can't see, of exposure. So that's essentially telling you that there is a wide range of exposure, very low levels. Most of the people are at very low levels, but there are enough women who are at high levels of aflatoxin exposure. So this is just to show you this is the sample size, and that's the mean and the median, and you can see that's the nature of the skewed distribution, and that's the geometric mean, which is about 2.1, your standard deviation, and the IQR. So then we started looking at different factors that could be correlated with these. So we said, does it matter? Does age matter? Does education matter? And what you see here is this is the mean age of women in our sample, and this is the mean education level. And what you see is that there is a negative relationship when it comes to age and education, but that's significant only for age. The next thing is we ran a lot of different bivariate relationships. We used ANOVAs in most of them. And here you have education where we categorized it. We said, let's see if we see something different. We find that the levels are consistent across. On the right side, you see ethnicity and religion. You find there is a little bit of a trend across, but there's nothing significant across those different subgroups when it comes to the serum aflatoxin level. The same thing goes for the trimester. There were a lot more women in our in the second trimester There is a higher level. The median looks higher, but actually it's not significant. The same thing goes for the wealth index. So whether you are rich or you're poor, it doesn't matter. In the subsample, we found it was across the board. Then we started looking at specific high-risk food items and seeing, is there a relationship of these foods with the presence of aflatoxin in these women? And here we have two very commonly contaminated products, maize and groundnuts. What you see here is the percentage of women who have consumed maize or groundnuts in the past week. And maize, obviously, is very low. We are on the Tarai, so it's about 5% of women reported consuming maize. But about 50% of women had consumed groundnuts in the past week. And here's the interesting part. The maize, obviously, it's such a low percentage, but what you see is that women, that 5% of women, they had significantly higher aflatoxin levels than the women who had not consumed maize. What was interesting was the groundnuts. As you know, that we had a lot more women consuming groundnuts, and what you see is that women who had consumed groundnuts the previous week had a significantly higher serum aflatoxin level than those who had not. So we are seeing something with maize and groundnuts. Rice, that was the other thing that's considered as highly contaminated, and what we looked at was essentially the consumption of rice, and rice is ubiquitous. So if you run a consumption frequency, you find that everybody's eating either 14 times a week, which is twice a day, or 21 times a week. So we really didn't see the relationship between rice and aflatoxin levels because there isn't much variability. So we decided to look at the production versus purchase of specific high-risk items. And so we looked at rice to begin with. And what you see here is most of the households are doing a combination of production and purchase. There's no single household that only produces rice, that is, that they have enough rice from their own production. They all supplement from the market. And you have about 20% of the households who actually do not produce rice at all. They have to purchase their needs. And what happens to them is the households, that 20% of those households who purchased only, had a significantly higher aflatoxin level than the households that had a combination of production and purchase. So that's very interesting, but that's still sort of telling you that there's a very big complex story. Because if purchasing in rice was the real relationship, you should see it on the other side as well. So we've got to unpackage this a lot more, basically. That's the bottom line. We looked at maize and groundnuts, and what you see, purchased foods are the cause of having high levels of serum aflatoxin. That would be completely incorrect, because if you look at maize and groundnuts, most of the households are actually purchasing their maize and groundnuts for consumption. And, but we don't see an association at all. That relationship doesn't exist. And we have to be a little careful here, and I have to put the disclaimer that these are bivariate relationships that we're looking at. So in conclusion, what do we know? What can we say right now with this preliminary data analysis? First of all, most of the women, 95% of the women had detectable aflatoxin level, but the distribution is skewed. So when you're doing any analysis or thinking of any analytical methods, you've got to account for that. The key thing is there's no difference in wealth, trimester, and education levels. We also looked at the spread across aflatoxins by the 17 VDCs, and we didn't see anything. We did see that age was negatively correlated. That's something that needs to be explored, because what that's somehow implying is that younger women had higher levels of aflatoxin. And we're seeing differences in those three high-risk items when it comes to consuming the high-risk item in the past 7 days. It's maize and groundnuts that seem to pop up. When it's purchasing rice in the past year, that's what seems to come up as sort of related to levels of aflatoxin. So essentially, our main conclusion is we know aflatoxin is ubiquitous in this subsample. We really need to now look at what's happening with the frequency of consumption of these high-risk items, because we were looking at only yes and no responses. What are the production and purchasing practices? We need to look at that further, because it's very complex. It's not as simple as you just produce it or you purchase it. And then understand what are the interactions and how they relate to aflatoxin. And then we have an entire slew of information that Joanna was talking about around handling knowledge and practices, which was really driven by her qualitative work. So we have we have data on about 75 different food items. And so there's a lot of information that we are sort of reading through right now. And we need to understand what's really going on. Also possibly look at different types of explorations, like doing aflatoxin quintiles, and then seeing if we find any relationships bivariate that allow us then to explore multivariate relationships. And at that point, I think we will have all our samples, because we're just sending the next batch. So we've got all 1,600 samples, or 1,676 samples analyzed. And so a lot of this work is going to happen on the full sample. So what are the future considerations when it comes to AFLA cohort when it comes with this data? We really need to tease out what the predictors are in pregnancy, because what we need to look at, that's our research question, is do women who have very high levels, who are on that sort of right end of the tail, compared to the ones who are at the left hand of the tail, do they have infants who have different birth weights and lengths? Do they have higher breast milk aflatoxin? We're going to be measuring that. What happens to aflatoxin for the babies at 3, 6, and 12 months relative to these women who have high levels? And how much of the stunting at 2 years of age, or the linear growth pattern up to 12 months, can we explain with these differential levels? And obviously, this is adjusting for all possible other observed and unobserved characteristics. So on that note, I'd like to thanks so much.